Palliative founder and CEO, Dr. Arian Nachat, is with us today to discuss meaningful advanced care planning and how palliative care and hospice work together. You're connected with the heart of hospice. I'm Jerry Finter, here with Helen Bauer.
Whether you're a family caregiver or an end-of-life professional, we're here to enhance your hospice experience by connecting you with information you can use about end-of-life care. Today's episode is sponsored by our friends at GrandPad. Do you have an older family member who's isolated, or do you feel disconnected from a senior loved one who lives at a distance? The folks at GrandPad have come up with the perfect solution, an easy-to-use device that connects older adults with family and friends using video chat, email, photo sharing, and more. Visit grandpad.net for details. I haven't had a good blooper in a while. Have you noticed that? I've been doing really well.
You have, yes, that's true. Why did you bring that up?
Just because I thought I should get credit for doing a good job. I think we should recognize that. Why,
of course. You have done exceptionally well.
That sounds very insincere.
I'm sorry. It was not. It was not insincere. It was not even...
Keep going.
Never mind.
Keep going. Mm-hmm. Dig it a little deeper, friend.
I know. Okay, people, you need to help me out here.
It's too late. We have a wonderful guest today, in all seriousness. She had no bloopers. She's awesome. She does some fantastic work. Dr. Arian Nachat holds dual board certification in emergency medicine and hospice and palliative medicine. She is the CEO and founder of Palliative, Inc. and Encompassing Care Alliance, which is a consulting and advocacy company focused on empowering institutions, clinicians, and patients to engage together in meaningful advanced care planning.
She specializes in minimizing patients' therapy and disease-related symptoms while optimizing quality of life by integrating the best of allopathic and traditional modalities. So this comes from their website, and it really is pretty concise with what they're talking about. They have a very distinctive mission.
They do.
And she's going to talk a lot about that on our interview. You're going to like what she has to say. You're going to learn a lot about palliative care and how it does dovetail so well with hospice. You're going to learn about her and her passion for palliative care and why this is so important to her. And also, we're going to talk about advanced care planning. I know. We talk about advanced care planning a lot.
It's worth repeating.
It is worth repeating. And we even do a little bit of confessing about advanced care planning. So just listen to the episode and you'll understand what we're talking about.
So here's our conversation with the wonderful Dr. Arian Nachat.
Dr. Nachat, it is good to have you on the Heart of Hospice podcast. Welcome.
Thank you guys so much for having me. I'm really excited about the opportunity to chat with you today.
Well, awesome. Well, we're glad to have you on the podcast. So you also have board certifications in both emergency medicine and in hospice and palliative medicine. That seems like an unusual mix of specialties. So do you ever find that these two different specialties are at odds with each other?
That's a fantastic question. I do get it often in terms of people think they're very sort of polar opposite. And when you think about it, in the emergency department, people think of what they see on TV shows, Grey's Anatomy, Chicago Hope, ER, take your pick of melodrama. And it's all about life-saving. Everybody's saving everybody. Everybody gets CPR. Everybody lives. Everyone walks out of the hospital the next day looking like the next top model. The reality is that that's not what we really see. And I've been in practice now for 21 years. This is my 21st year as a physician. And the reality is very different, and resuscitations in the ER do not often look that pretty. It's probably one of the most invasive and aggressive physical acts we do to a human body to try and keep it alive. And one of the things that I think makes emergency medicine physicians particularly good as palliative care physicians is we really see when medical care is no longer beneficial. We see when what our interventions are likely to cause more pain and suffering and be more burdensome than result in a good outcome. So I think we have a very unique perspective because we spend the majority of our time resuscitating people. And so as a palliative care physician, I bring all of that expertise to bear when I look at patients, and I can see what the trajectory looks like, and I can anticipate sometimes better what it will look like if they get into trouble, if they become acutely decompensated for whatever their illness is, and they wind up in my ER and I'm wearing my ER hat. I can usually anticipate who is going to do well and who is not in a way that's very different.
I think that's an important piece of wisdom, an important perspective as a physician, as a clinician to have. You know, in healthcare in the United States, we're very siloed, and I think it's hard to sometimes integrate what those transitions between the different silos would look like for a patient.
Absolutely. And I think that it's one of the biggest points of education that I provide when I'm in the ER. So right now I work clinically as an emergency physician at two sites that are very polar opposites. So at Balboa, which is the Naval Medical Center, it's predominantly for active duty service members. And we do get some retirees who come there, but the majority are young, healthy, active, generally well. Then I have my polar opposite experience working at the VA, where I work with veterans who now have some very significant chronic illnesses, some related to their service, some not. And the trajectory that they go through is one that is very individualized and very unique to each and every patient, right? No one host responds the same way to an illness as another. And so having that perspective really affords me a unique vantage point where I've seen both life-saving, life-ending, acute, chronic. I also do traditional Chinese medicine, so Eastern, Western, inpatient, outpatient. I've really seen the healthcare chessboard from every angle. So I feel I have that 30,000 vantage point view that a lot of clinicians, because of those silos, don't necessarily have. And it's not a criticism. It's just, why would they? Unless they see the sphere from multiple angles, they don't have a reason to have that experience and knowledge. And so, you know, one of the biggest challenges education-wise is most people, when I walk into a room and I say I'm the palliative care physician, they look at me with this look of terror and horror of, am I dying? And I joke around with them regularly and I say, I don't have a shiv and I don't have a black cloak. You know, there's this expectation that I'm the Grim Reaper who walked into the room. And so I think it's really important for people to understand the difference between palliative and hospice. And it's not that hospice is the Grim Reaper either. It is not. But I think there's this perspective, and it's due to a lot of different reasons, politically, economically. A lot of polarization has happened in healthcare and in this country. People assume that if you go on hospice, you don't get care, and that you're expected to die within a couple of days or weeks. What most people don't understand is that palliative and hospice are a continuum of each other. Patients who wind up as palliative patients have some sort of end organ dysfunction or serious illness, but they can potentially live with that for decades. I'm sure many people listening know people who have Parkinson's or cancer, or congestive heart failure, COPD, diagnoses that people can live with for a very extended period of time. The difference is that when you're palliative, you're in what I refer to as a disease-modifying state, meaning we're still doing something to change the behavior of your illness. There's something I can do. If I were to use cancer as an example of this, the freight train of cancer is coming down the tracks, but I'm going to start putting brakes on that train in different ways, whether it's surgery or immunotherapy or radiation. There's something I can do to change the way your disease is behaving. So that puts you squarely into the palliative bucket, so to speak. And what happens is over time, we may either have less things that we have at our disposal in our toolkit to help put brakes on that illness, or we may not. You know, with oncology, for example, one of the most exciting things about oncology is we've gotten so much better at targeted therapies that there's constantly new things coming down, the pike that we can use to modify that patient's illness potentially. The transition to hospice is one that I think a lot of people have misconceptions about. And really the way I explain it is there are two ways you wind up being a hospice patient. One is either we've run out of disease modifying treatment. And as a clinical team have said, there is no more modifying treatment I can offer you. And then the patient becomes eligible for hospice, or a patient can choose to not participate in treatment. It is not uncommon for me to talk to patients who have said, I've lived a good life. I've done all the things my doctors have told me. And I really just want my quality of life right now to be focused on spending time with my friends, my family, and doing the things that I love rather than spending more time hanging out with you. As much as I like you, Dr. Nachat, I'd rather spend it with other people. And I think that's a really reasonable choice for people to make. And it's very much, again, an individual, values-driven, personal decision that patients and families get to make. And we as palliative and hospice clinicians, our job, our role is to give them their voice and allow them to have agency in making those decisions, but ensuring that they understand the risks, the benefits, the alternatives to what their choices are.
So one of the problems that we often face is that many people just simply don't understand what palliative care is. They don't understand what it does and how it can provide care for them in a way that's really beneficial for them, even though they can still continue aggressive care if they want to. So how do you think we can get the message out about palliative care? How can we change the view, or actually not only change the view, but actually help people to know more about palliative care?
It's a narrative story, really. We have to change the narrative. I think that patients have been unfortunately put into a place where they fear talking about death and dying. I think that we, both as clinicians, have been trained to intervene to always help save people. There's this savior syndrome. And the reality is we're all going to die someday. Right. I started writing a TED talk that I'm hoping to give in the not too distant future. And the first line in it is, I'm dying, but not today, at least not that I'm aware of. And the reality is we all are dying. From the day you're born, the next thing you're going to do at some point is die. That's the only 100% guaranteed experience we're all going to have.
Right.
So I think that this fear mongering and anxiety that people have about talking about it and dispelling the fact that really talking about it doesn't make it happen. I joke around. It's not like, I'm going to date myself here, but it's not like in the movie Beetlejuice. If you say Beetlejuice 3 times, Beetlejuice is going to appear. Talking about how you want to die doesn't hasten it. Talking about what's important to you and what qualifies as living for somebody is not going to suddenly expedite the dying. And so I think the first thing is to stop sort of fear mongering more than anything else. And then a lot of it is education. Just because we have a lot of bells and whistles and tools at our disposal doesn't mean that it's always appropriate to use those tools. And I think that that's something that a lot of people can relate to. Just because I have all this scaffolding, that's how I like to describe palliative medicine. I have scaffolding, and your body is what's in need of that scaffolding. And, you may be someone who needs just a little bit of scaffolding to help hold you up, and it's not burdensome, and it makes you feel good, and you get to go and do the things that matter to you. Or you may be someone who requires an enormous amount of scaffolding that really inhibit what living constitutes for you. And you may decide, you know what? I don't really want all that scaffolding in place. And so I think number one is education. We need to educate people into understanding that palliative medicine is not death panels. Palliative medicine is about making choices that are very individualized to what your specific illness, circumstances, and belief systems are. And that our job is to really support you in expressing that, whether it be by helping you put that and commemorate that in writing in the form of an advance directive, or a POLST form, a physician order for life-sustaining treatment form, whether it be navigating it by having meetings with the palliative care team. Just like you go see your cardiologist, you come see the palliative care team, and we sit down and we talk to you and we suss through some of this stuff, especially when you come to decision points where you're like, I don't know what I want to do. This oncologist is offering me surgery and radiation, and this oncologist is offering me immunotherapy, and I don't really understand all this medical jargon, and helping them suss out what really speaks to them and what does the data show. So first and foremost, it's education. Second, I think we need to do a lot more grassroots advocacy, frankly, across the country. I think that we still have clinicians who are fearful of palliative medicine. I still get oncologists and other clinicians who, they're talking about putting an LVAD into a patient, a left ventricular assist device, which is basically a terminal treatment option for someone with heart failure. And they don't talk about, what is life with the LVAD necessarily going to look like? And they've never talked to them about goals of care. And the patient has no advance directive and they don't have a physician order for life-sustaining treatment. And so I feel like there's also a huge responsibility within the medical community that if we're going to do interventions of any sort, dialysis, permanent pacemaker, a defibrillator, an LVAD, any kind of intervention that is, really kind of putting the brakes on that patient's ability to have a peaceful death, we need to talk about why we're doing it and what would be the circumstances under which they would not want that anymore. And I think that conversation is severely lacking. And I guess last but not least, one of the reasons that I'm building my company Palliative is because there just isn't access to enough palliative trained physicians and nurses in this country. There are 7,600 palliative care boarded physicians, and there are 14 million patients who need us. And that number is expected to hit about 63 to 65 million by the year 2035. And right now we train about 500 fellows a year to become specialty trained in hospice and palliative medicine. And there is no way for us to train enough people fast enough to be able to support 65 million patients who have those.
For me as a nurse, being in nursing for just over 30 years, I had no training in palliative care. It was not a specialty. Palliative care is the youngster of all the different specialties. It's relatively new. So there are a lot of clinicians like me. I wouldn't say I'm old, but I'm in the last 3/4 of my nursing career, I guess. So when it comes to education, I know that there is a federal act that they're looking at to increase our bandwidth, deepen our education. So when it comes to clinicians, there is definite education lacking there as well.
Absolutely.
Can you speak to that?
I can. So it kind of reflects what's going on nationally in terms of the presence of palliative medicine. So if you look at a map of the country and you look at what areas of the country are served by palliative medicine in a robust fashion, it's basically major metropolitan areas that have academic centers and medical schools and residency training programs nearby. And the majority of the country, which is not those areas, does not really have access to palliative medicine. Only 17% of rural hospitals have palliative medicine offerings. And to me, that's just abhorrent and really speaks to the divide that happens in this country in terms of the haves and the have-nots, and in terms of access to care and equity when it comes to accessing care. And so one of the things that needs to happen is we do need to educate everyone about what palliative medicine is. It needs to stop being, using the phrase, the redheaded stepchild of healthcare. We need to stop being that bad word that no one wants to talk about. And I think that comes from cultural belief systems where everyone thinks we should do everything that we can to help people live for as long as possible. I think some of it is also the economics of it. Palliative medicine is a specialty where we take an enormous amount of time to spend with patients and families. It's not a specialty where I walk into the room, I have a 15-minute conversation, I leave, and I bill that way. And so it also is a function of the economics of healthcare. And I think understanding the value of what palliative medicine brings to insurers and healthcare systems is a whole other conversation we could have an entire podcast about, which has to do with healthcare in this country overall. But, we have a sick healthcare system. We have a system in which we provide the majority of care when someone is profoundly ill and towards the end of life, rather than upstreaming it and really providing preventative care and support so that the end of life is not this major interventional time where we're doing things that frankly are going to move the needle less so than if we had intervened a lot earlier. And so reimbursement for palliative medicine has always been an issue, which is one of the reasons a lot of hospital systems have not fully supported it, because when I spend an hour and a half to 3 hours with a patient in a very extended family, that's not the same as a cardiologist building for 3 hours worth of interventional procedures. Our value system in this country in terms of what we believe is worth paying for is questionable. I think our moral compass in healthcare has gone out the window quite significantly. And I think, frankly, patients are fed up. I think clinicians are fed up. I think that we all want to see a return to a much more patient, clinician-centric experience where what we offer is truly valuable to both the patient and the clinician. Most clinicians don't go into healthcare because they're looking to make $1 gazillion. They're going into healthcare because they genuinely care about people. And when you have insurers and systems telling you, you only get to spend 15 minutes with a patient, and by the way, 11 of those 15 minutes are going to be spent with you clicking through an electronic medical record, that's really a lot of value to the patient, and certainly has not been something clinicians have enjoyed.
The team at GrandPad has created a great device to help families stay connected despite distance and lockdowns. The GrandPad utilizes a simple format that allows seniors to easily access technology. Internet access, video chat, and email, along with games and music, are just a few of the features the GrandPad offers. GrandPad comes with 4G LTE cellular service already included, so there's no need for Wi-Fi. Users can create a private family network that allows for secure photo and video sharing. At the core of the GrandPad team are the Grand Advisors, a group of seniors that continually inspire, test, and guide the development of GrandPad. The company has built a platform that empowers seniors of all ages and technological skills to safely connect with family, friends, and caregivers. No spam, no robocalls, only connections with those you trust, family, friends, and caregivers. The GrandPad team strives to create a world where no seniors are lonely or isolated. Using innovation and current communication tools, they keep older adults connected to their younger family members. To purchase a GrandPad subscription for your loved one, visit grandpad.net. Or to purchase multiple devices for your business or facility, visit grandpad.biz. Now on to today's episode. So in some ways, it sounds like maybe one way to improve the scope of palliative care is, as you said, to go upstream and educate the clinicians about what palliative care can provide, because they're the ones who will be talking to the patients. They're the ones who see the patients. They're the ones who see the people who are in need of palliative care. So educating the clinicians on when to use palliative care, how to talk to people about palliative care is going to be important. So you started your company, Palliative, and you are the CEO, you're the founder of Palliative, as well as the other company you have, Encompassing Care Alliance. So how do those two businesses focus on creating the meaningful advanced care planning? Because that seems to be part of the discussion as well. Advanced care planning needs to be there to really move things forward in a meaningful fashion. So how can Palliative help that happen? What is Palliative doing in that regard?
So when the pandemic hit, I had decided that I would start my own concierge practice. And the main reason was, again, I wanted to provide patients the level of care that I felt was appropriate for them. But one of the things that hit me and really made me take a step back is I realized I could help, a few families, a few, patients, maybe one healthcare system. And I found myself really looking at the equity issues related to the delivery of palliative care and the fact that the folks who probably could afford me as a private concierge doctor were the same people who probably had access to palliative care within their hospital systems and lived in areas where they could access that care. And so I really shifted from predominantly doing a concierge practice to deciding that I really wanted to build something that was accessible to anyone, anywhere, regardless of their diagnosis or prognosis. And so the vision for Palliative is really to create a platform that allows anyone who needs information, education, actual delivery of care or goods related to the palliative care sphere into one sandbox, so to speak. Palliative is built on 3 pillars, essentially. The first pillar is the education and support piece. Patients often don't know if they even need palliative medicine. They don't know when it applies to them. Most people don't necessarily even understand the word. And so the first pillar is the educational piece, where people can access videos, blogs, information that is all evidence-based. And people can really sort of self-select in and go, okay, is palliative care right for me? I have one of my blogs is Palli 101 versus Hospice 101. Which one do I belong in? And really give patients and families the opportunity to self-select for themselves where they think they fit on that continuum of care. The second thing that's part of that support is that we know that patients and families going through a significant illness, it's the equivalent, I use the analogy of climbing Mount Everest, right? It's really hard. There are a lot of pitfalls. There are a lot of cracks in the mountain. And what palliative medicine can do is we can help you up the mountain, we can help you down the mountain, but we know where the cracks are in the mountain, where you're Sherpa. And patients want to talk to other patients, and caregivers want to talk to other caregivers. And similarly, I've found that clinicians really want access to other clinicians they can talk to about their patients. And so part of the Palliative platform is a patient HIPAA compliant portal where patients can find other patients with their own diagnoses. They self-select into that and can say, you know, I'm a triple negative breast cancer patient in my 40s with young children. I'd like to talk to other moms who are going through this. I feel the need to share with other people and hear insight from other people that, you know, how did they talk to their kids? What did they share with their kids? What are my fears as a mom, knowing that I may not make it to see my kid's 18th birthday? You know, so having the opportunity for social support within diagnoses for both patients and caregivers, and then for clinicians who are seeking additional support, where maybe you are a rural family practice doc in the middle of Kentucky, and you don't know much about palliative medicine, but you've heard about it and you want to talk to a physician who specializes in palliative medicine. So the educational pillar is very important to us, the education and support pillar. The second pillar is really the telehealth and delivery of actual palliative care services. So we have board certified physicians, nurses, chaplains, social workers, and case managers who can literally take over and provide the telehealth palliative care support. And over time, probably will have boots in the ground throughout the country. Right now, we're based only on the West Coast. And our hope is to really use evidence-based medicine and AI and machine learning to be able to identify patients at risk earlier on, so that we can start recognizing the patterns and help identify those patients before they need that ER visit, before they need that ICU hospitalization, and kind of bring them off from the cliff earlier on. And then the last piece of it is the marketplace. And so part of the marketplace is that patients need more than just medical care. There are a lot of aspects in the journey of death and dying that patients really want to explore other things, whether it's they have legal needs and they need help figuring out, you know, how to do estate planning, or they want to do legacy work and they have letters or videos or messages that they want to be able to leave their loved ones, or create a book, or create some sort of lasting memorial for themselves or their family members. Or if they need things like pharmaceuticals delivered to their house, or they need to find a reputable PT or occupational therapist who can come into their homes, or they need to find caregivers. So there are so many things and so many facets to what caring for a patient with a serious illness looks like. I decided I wanted to put it all at the fingertips of anyone who needed it. And so we're hoping to essentially provide access to everyone in a way that allows them to not have to go, you know, where on Dr. Google do I have to go to find this thing or that thing?
When I think of that 15-minute visit, let's focus on advanced care planning for just a minute.
Sure.
If I went as a 56-year-old healthy middle-aged person and went in to talk to my doctor and right? It's my annual checkup. I probably don't see him more than once a year.
Mm-hmm.
And I said, I want to talk about advanced care planning. Yeah. He's supposed to be able to bill my insurance for this. And, if it's an older person, they're supposed to be able to bill Medicare for that. 15 minutes. How effective do you think our advanced care planning conversations are when we're confined inside this time-sensitive, time-driven system?
I think that the value of the conversation is the most important aspect of advanced care planning. I have lots of patients who come in who have completed an advanced care planning form with their attorneys. And no offense to the legal profession, I love the fact that they're endeavoring to get some documentation put in place, but they can't customize that patient's advanced care planning document to their medical scenario because they're not clinicians. They don't understand whether this is a patient who would benefit from being on a vent or not being on a vent. And so I think that, can you get a lot done in 15 minutes? Absolutely. Is it better than no conversation? Absolutely. I'll take it. I'll take any conversation that opens the door.
Sure.
And yet I'll also say that I've had a fair number of patients who, because the conversation is not as in-depth as it needs to be, come in with advanced care planning forms that frankly don't reflect what their actual wishes are because no one had a thorough conversation. My least favorite question I overhear my fellow colleagues say is when they'll walk into a room and say, so if your heart stops while you're in the hospital, do you want me to try and restart it, as if it's a light switch? It's not a light switch. We do more informed consent for a laceration repair than that. And so I feel that when the conversations are done in that fashion and they're very generic and they're not specific, what happens is people elect to have things done that they didn't actually understand. And so, when I talk, for example, to a patient with advanced cancer, say stage 4 pancreatic cancer, and they say, oh no, I want you to resuscitate me. And I sit down and I say, well, what am I bringing you back to do? What are you hoping is going to come of me resuscitating you? And then they think about it and they go, I'm in excruciating pain. I can't do the things that I want to do anymore. I can barely eat. I'm suffering. Oh yeah, maybe having a natural death where if my body says enough is enough, it's okay to respect that. That's a very different conversation than, hey, if my heart stops, sure, go ahead and try and restart it.
Right.
Anything we do in medicine, one of the adages that they teach in medical school is when you order a test, what are you going to do with that information? Right? Don't order the test if it's not going to be of any service. Similarly, resuscitating somebody to come back to a life that is already not a quality of life that is acceptable to them, or where they're already struggling and suffering with the expectation that their quality of life is in any way, shape, or form going to be similar to what it was before a cardiac arrest, is not realistic. And that's a hard conversation to have with someone. And it requires nuance and being delicate and knowing the patient and knowing that family. So can you do it in 15 minutes? Maybe. If you're really good at it and you know the family and the patient and their illness really well, and you've sort of created sort of the stepping stones to have that hard conversation. But most patients don't have that experience.
No. So what this makes me think of is we have a tendency to say, do you want us to do everything?
Yeah.
What in the living crap does that mean?
Right.
I think clinicians don't want to enter into those conversations with depth. First of all, because if they're not familiar with hospice or palliative care, what this looks like, emergent medicine, they don't really know what those consequences are, what the following events are going to be. And then you have to deal with the family culture, the emotional culture, the psychosocial culture of that patient and their family unit, their caregiving unit. And we also don't have training on how to manage that.
Right.
I don't think adequately anyway. And then you have to take the time to deal with it.
And that's hard.
And our system isn't set up to do that. Yeah, it's very difficult.
Yeah. And that's why one of the pillars of Palliative is the education piece, not just for patients and for caregivers, but for clinicians and frankly, for healthcare systems. If you're part of that rural hospital in middle America, where only 17% of hospitals have access to palliative care, if you're in the other 83%, you may not have any idea what I'm even talking about. So doing trainings where we can go out and fly out and educate people and do a grand rounds and say, let's talk about death. I have a talk called One Foot in the Grave, when the life-saving measure is letting go. Sometimes that is the life-saving measure. Sometimes that is exactly what that patient wants and needs, and their family wants and needs, but no one has offered that as an exit ramp for them. And I'm not talking about euthanasia or physician-assisted suicide. I'm talking about just choosing to not intervene anymore.
Right.
Those are very different conversations. And I think that it's very anxiety provoking for everybody. And so we really spent a lot of time when creating the vision board for Palliative about where are the pain points and where can we make a big difference. And one of them is clinician resources and education, and being able to educate the folks who are providing the care as to what non-beneficial care is and what does non-beneficial care look like, and under what circumstances might you say, yes, I can do chest compressions. Yes, I can put an LVAD in. Yes, I can do X, Y, and Z. But let's talk about what that actually looks like, and then tell me if that's what you want. That's what informed consent is.
Well, when we say quality of life, shouldn't we also consider quality of death?
Absolutely. But I don't think talking about palliative medicine, about talking about dying, has helped the narrative. I think palliative medicine is about talking about how you want to live. It will inform how you die, right?
Yes.
But if we talk about it as, let's talk about your dying process, people are really, really reluctant to get into that conversation.
This is
but
true.
When you say to somebody, let's talk about how you want to live, what does it mean to you to live? What brings your life value? What brings you joy? What are the things you want to still be able to do that without being able to do those things, you're like, meh, what am I doing here?
Right.
So I don't like talking about it as, let's talk about how you want to die. To me, it's how do you want to live? And that will inform how your death goes. And you can still plan for it and you can still talk about it. I hosted a Clubhouse talk with Guy Kawasaki. I don't know if you know who he is. He was one of the initial Apple founders. And he founded Canva, which is about how to curate documents and presentations. He's all about how do you deliver messages, right? And I invited him to have a talk with me about curating death. How do you curate your death? And it was really interesting because when we started the conversation, and it was an hour and a half long conversation on Clubhouse. It initially was supposed to only last 45 minutes, and it took a really long time, and it was great. But even when we started the conversation, Guy was taken back a little bit, I think, because, initially he was like, oh, I can talk about curating anything. I'm like, yeah, but I'm planning on talking about curating death. This is a little bit different probably from your usual wheelhouse. And so initially he was like, I don't really know, and was kind of stumbling a little bit about it. And then the more we talked about it, by the end of the conversation, he was referring to the movie Coming to America 2, where the main character is designing his funeral and has like the Pointer Sisters are going to come and sing, and I want to do this, that, and the other. And he's like, you know what? Dang it, I'm not going to wait until I'm on death's doorstep to buy the car that I really want to, drive. And I'm like, that's exactly why we have these conversations. Because now the choices you're going to make about how you're going to choose to live your life are going to be very different. And it doesn't have to be scary. It can be fun and it can be playful. And, I think humor is underutilized in discussions about death and dying.
Oh, absolutely.
I think humor is important. It helps us process difficult things and shine a light on them in a way that is more palatable. One of the blogs that we're creating for Palliative, I haven't settled on the final name of it yet, but it was something along the lines of having like the New York Times, but the Death Times, and really having a column about things that people are hopefully going to smile and laugh about a little bit. like, how to come back and haunt your relatives effectively. um, things like that. Because when you make light of it and you think about how we celebrate every other aspect of life, right? We celebrate having babies and graduations and jobs and promotions and careers and retirements, but we don't celebrate dying. And it doesn't have to be this horrifically sad, morose event. It can be beautiful and really celebrating of the things that that person accomplished and contributed and who they loved and how they loved and what made them unique and special and all of those things. So again, it's about changing the narrative. And so I'm cautiously optimistic that Palliative will succeed in doing that, but more so that more people will come join this bandwagon of changing that conversation.
So I want to ask you something a little bit personal, but I think in answering the question, you will also help to sort of define the important things as well. So if you're designing your own advanced care plan, what are the 3 most important items that you want to put in your advanced care plan?
I'm laughing internally about that question because my lawyer, when I completed my advanced care planning document, had never seen one as explicit in their entire career of about 30 years of doing law. So I was very explicit in my advanced care planning. So first of all, the decision to disconnect me from life support, I said, had to be by agreement of 2 out of 3 physicians of my choosing, and they could not be people who were actively involved in my care. And I listed 10 physician colleagues who I trusted without hesitation, who I knew could review my medical records, who knew me really well, and who would be able to make a determination of whether it would be something that would be consistent with my wishes to stay in that state or not. I know most people don't have that possibility of being that explicit. But I would say the number one thing is you need to pick people who really know you and get you and who are medically savvy enough to be able to understand the information being presented to them. And you need to be able to talk to them about what your thoughts really are about it. I've shared this story before and I'll share it here again. My brother-in-law had listed me as his emergency contact and didn't tell me he had listed me as his emergency contact. And unfortunately experienced a cardiac arrest that was really out of nowhere and had passed. And I was the one who got the phone call. And I wound up being the one who had to break it to his wife and his teenage son. And that was probably one of the most difficult things I've ever had to do. And I deliver bad news all the time. And the reason it was difficult is because no one was prepared. No one knew that I was the emergency contact. I didn't know I was the emergency contact. And so I would say number one is make sure that you pick 2 to 3 people who are your surrogate decision makers, who are people who know you well, understand enough about your medical condition, and are capable of processing the information that the medical team is going to likely be discussing with them. And make sure that they really understand what you want and don't want and why, the why of those decisions. I would say the second most important thing is to review that advanced care planning document with some regularity. The number of patients that I talked to who completed an advance directive a decade or 2 ago, and it's been sitting in a safe in someone's house and no one knows where it is or what it says, is not really super helpful. So advanced care planning documents are something that are living, breathing documents and should reflect where you are in space and time. People get divorced. They have their spouse listed as their surrogate decision maker, and that's someone they may not want anymore as their surrogate decision maker, or someone that they care about may have passed who was on the list who's no longer available. So reflecting on what your wishes are based on where you are in space and time is really important. And another trick I tell people nowadays is take a picture of your advanced care planning documents, have it on your smartphone. Most people have access to a smartphone these days, and share that document with your main healthcare system, your physician, and anyone who's your surrogate decision maker should have a copy of it on their phone as well. And then I think last but not least, I think it's an opportunity to really reflect for me on at what juncture would quality of life be too impaired for me to not want to be here. And I think that that's a hard one for everybody. Some people I need to stay completely physically intact. If I'm not physically intact, I wouldn't be okay with that. But what's interesting is having worked with enough patients over time who have had losses, physical losses that they didn't think would be bearable to them, who then realize that they can still have a very valuable life despite those physical losses, has really taught me that what I think I know I want now may not actually be what I want in that point in time. So I think just being really honest and thoughtful with oneself and with one's family, and reviewing it again. It's a living, breathing document. I've had an advance directive since I was in my 20s because I used to jump out of airplanes and kind of figured it'd be a really good idea if my parachute didn't open for somebody to know what to do. So, how I felt about things when I was in my 20s versus how I feel about things now in my, late 40s with 2 young kids is a very different conversation. And I suspect will be a very different conversation in another 15 or 20 years as well.
Right. Yeah, that's a really good advice. Thank you for sharing that, because I think most people don't even know where to begin when it comes to advanced care planning. And I'll have to confess to that myself.
Don't do it.
You don't have a document.
I don't. And we have discussed advanced care planning repeatedly on the podcast, and yet I still haven't done it. But we're going to do it this year, and it's going to be done. So I'm one of those people who I know I need to do it, and yet I haven't done it. So I think hearing what you're saying helps me to realize I don't have to know all the ins and outs of it, but I do need to have some thoughtful moments when I consider what needs to be done and how it needs to be done. So I'm grateful for what you're sharing with us, because I have a feeling I'm not the only one that needs to do.
He's trying to rat me out without saying it.
Well, I'm happy to complete an advance directive with both of you if it would be helpful to have someone else participate in that conversation.
I think that's where we need an intervention. I think that's what we might need.
Right.
But that's why palliative care exists. And that's why palliative care is such a great thing, because just as it's difficult for you guys to have that conversation, and you understand what we're talking about, probably more intimately than most people.
Right.
It's a hard conversation to have because it forces you to acknowledge your own mortality, which I think everyone is a little bit more open about now because of the last couple of years with COVID. I think people have recognized their mortality in a way that they might have not previously done. But that's why having a third party who you don't have to worry about what you say to them.
Right.
I tell patients and families regularly, you don't have to meet with me together. You can meet with me separately, because what families worry about is sometimes different than what the patient worries about. And any kind of interesting family dynamics, and we've all got them, love to come out at points of crisis, right?
Right.
And so, a patient may be worried about their spouse or their kids or their grandchild or whatever the case may be, and not share with their family what their wishes and hopes and dreams are related to their illness because they don't want to burden them. Mm-hmm. Conversely, the same is true of families. Families often don't want to say what their thoughts are about things because they don't want to stress out the family member who's the ill family member. Yeah. So having a third party, and it doesn't have to be a palliative care physician. It can be your personal physician. It can be, a good friend. It doesn't have to be a palliative physician, but what we specialize in is in having those really challenging conversations. And so when you get to a point where there's stuff I want to say out loud, I'm afraid to say it out loud to Helen, because Helen and I have been working together for forever. And I'm worried she's going to think it's weird that I want to have X, Y, Z. Sometimes talking to someone who isn't that close gives you the opportunity to be more open and transparent and not fear judgment. And our job is not to tell you what to do ever. My job is not to tell a patient they should pick, one thing or another on the form. My job is to make sure they understand what the choices are on the form and relate it to how they're doing medically at that moment in time.
Right.
Yeah. It's sort of an impartial person. An expert, but not a care provider somebody who doesn't have skin in the game. I think that's important.
Right.
Yeah.
It is, because then you can have an honest dialogue and not worry about, well, is this person guiding me? And I'm not trying to throw specialists under the bus, but when you've been caring for someone with an illness, and I'll use my dad as an example. So his pulmonologist was taking care of him for 20 years before he was diagnosed with lymphoma. And my dad thought he was the best thing since sliced bread. This physician could do nothing wrong. He was the chief of the department at a very prestigious hospital, somewhere I won't name. And I remember I was a second-year emergency medicine attending. So I was fairly fresh out as an attending, and I had visited him in the hospital. He was admitted for neutropenic sepsis from having chemo. And I was just flipping through his chart, and I'm like, he's not on GI prophylaxis. He's not on DVT prophylaxis, things to prevent him from developing an ulcer in his stomach or a blood clot. And I called the doc and I was like, hey, I'm just concerned about X, Y, and Z. And he basically read me the riot act of, I'm Dr. So-and-so, and I'm the chief of blah, blah, blah. And, how dare you question me, this, that, and the other. And, 2 months later, my dad had a massive pulmonary embolism, thankfully a non-fatal one. And it's hard because he was looking at my dad through this really narrow lens of having known him for so long that he felt that there was nothing anyone else could add to the conversation. And I think sometimes specialists become really attached to their long-term patients, and it's hard for them to have this conversation and to be able to take a step back because they want them to live longer. They really deeply care about those patients. And it's hard for them to let go, almost as much as it is for the patient to let go. So if everyone's holding on to that lifeline and clinging onto it, it's hard. So having an impartial person or someone who's less directly involved and can look at all the elements of a case is, I think, very helpful.
I think so.
Yeah, definitely.
It just sounds smart.
Well, this conversation has been extremely enlightening. And
I feel like we could talk for another hour.
I know. This has been very good. So tell us how our listeners can find out more about Palliative.
So right now, Palliative is in a beta testing phase, so it is not open to the general public, but we have the ability for people to, subscribe here so that they get updates for when we open it up. We wanted to be really thoughtful about making sure that what we could offer is something we could offer consistently and across the board to the caliber that we wanted to. So right now we're doing a beta trial actually with an oncology company that's curating clinical trials for patients with advanced cancer. And so we're testing it with that patient population specifically to see what we thought patients would want and clinicians would want is really what they want. And just making sure that we get all of the bugs out before we open it up more broadly. But you can still go to the palliative.com website. You can still look at videos. You can still look at educational materials. But hopefully in 2023, it'll be more robust and available to the general public. I would say that for anyone listening who has wondered whether palliative care is right for them or, hospice is right for them or their family member, and they didn't know the answer to that, I'm hoping they walk away from this going, these are not the scary people. We're actually the warm, touchy, fuzzy people. And it's worth a conversation, and looking for someone locally in their area and reaching out and having a conversation would be fantastic. There are several options for advanced care planning forms out there. There's the POLST.org, POLST.org, which gives you a state-by-state physician order for life-sustaining treatment form. I suggest everybody look at that. And then there's a great nonprofit called Prepare for Your Care that has advanced directives that are written in a format that is much more patient-centric. I tend to use that with my patients. And it's much more narrative in nature. It's not here, click this box, click that box. It's not written in legalese, as I like to say. And it's available in multiple languages, I think 12 or 13 languages. so people can download those forms in a language that is clear and makes them feel comfortable. So I would say those would probably be the things I would recommend our listeners do. And I'm always happy to come back and chat with you guys another time when Palliative becomes open to the general public. And, being a startup, we are always looking for people who believe in what we're building and want to contact me. They can do that at info@palliative.com if people are interested in investing in the company.
We will have links to everything and include the email in our show notes, so anybody listening can go straight to you, connect with you, check out the work that Pallitive's doing, and communicate with you. Thank you. Thank you. The information, I learned something from you every time we've talked.
Aw,
the information isn't valuable. You have a great voice. Jerry always says, you have something to say and people need to hear it. You are one of those people.
Aw, thank you so much, you guys. I really appreciate it. Happy to talk with anyone, anywhere, anytime. I joke around. We're big Harry Potter fans in my household. And I joke around about the fact that I'm building Dumbledore's army of do-gooders. There is so much work to be done in the palliative and hospice spaces. And I feel that the more of us who can talk about it and can change the scary narrative into one that's welcoming and inviting and gets people to engage, the more the better.
Absolutely. Well, thank you so much for spending this time with us. And we will have you back again when Palliative is ready to launch. Let us know. We'd be glad to talk with you again.
Thanks so much, you guys. Appreciate it.
I learned from this lady today. Yes. I learned from her, and that's good. That is such a good connection. We can learn from each other across the continuum. And I think that's one of the reasons we are so siloed and so separate.
Right.
We don't talk across to each other. We haven't been educated. We haven't been trained. And so it's so easy to just stay in your lane. Staying in your lane is important.
Yeah, wait. Yeah.
Yes. But doing your own thing without an understanding of where the patient has come from and where the patient is going does not do your patient any service.
Right. One of the things that was discussed rather extensively in our interview is about education and how important education is, because the problem we have come to realize is that many people do not understand palliative care.
It's true. I have a limited understanding. I am still learning because it is, while hospice includes palliative care as a specialty is unfamiliar to me.
And I think that's true for a lot of hospice professionals. They know about palliative care. They know how to care for a patient. Can I say palliatively? Is that a word?
I don't know, but with palliation, using palliative measures, yes.
Right. So that's what we understand. But palliative care by itself is sort of a new specialty.
Newer, yes.
It is. And it's not hospice, although hospice is palliative care. Are we getting confusing here?
It is confusing, but so this is the way it works. All hospice contains palliative care, but not all palliative care is hospice.
Right.
And that's where it gets a little bit messy for those of us old people that have been doing this for a while. But so here's the deal. Today we learned from her, and we hope you as a listener have learned as well, and that you will go out. So I'm going to go out on a limb and say that there has to be some professional individual accountability, because we talk about, there needs to be education. This is what I will say to you. If you are an end-of-life professional, if you are a healthcare clinician, there is absolutely no reason that you cannot be educated, and it is up to you to gain the education, to gain that knowledge. It is out there. For goodness sake, stop saying you haven't been trained and go and get it. Absolutely. So we would invite you and encourage you to go to Palliative.com. That's PALLITY.com, and check out their website. There's a ton of information on this website. There's blogs there. There's videos there. There's
all the resources that you might need to learn more about palliative care right there on their website. And so this is the website for Palliative Inc., which is the company that Arian has founded, and she is the CEO for that company now. Learn more about palliative care from the experts.
Thanks for listening to The Heart of Hospice. I'm Helen Bauer here with Jerry Finter. Because we know your hospice journey is 24/7, you can always find us at theheartofhospice.com. Subscribe to the podcast wherever you're listening and leave a rating or a review on Apple Podcasts.
To connect with us, just send us an email to host@theheartofhospice.com. You can also find us on social media. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.